Welcome to this session on epidemiology. Actually, we've already looked at epidemiological examples. In the previous session, we didn't use that word. For example, we looked at a study of Avandia and the risk of heart attack. The definition of epidemiology is a study of how often diseases occur in different groups of people and why. Epidemiological information is used to plan and evaluate strategies to prevent illness and as a guide to the management of patients in whom disease has already developed. Like the clinical findings and pathology, the epidemiology of a disease is an integral part of its basic description. Related to epidemiology is research design. And research design refers to the overall strategy that you choose to integrate the different components of a study in a coherent and logical way, thereby ensuring that you effectively address the research problem. It constitutes the blueprint for the data collection, measurement, and analysis. The function of a research design is to ensure that the evidence obtained enables you to effectively address the research problem logically and as unambiguously as possible. A common mistake made by researchers is that they begin their investigations far too early before they have thought critically about what information is required to address the research problem. Without attending to these design issues beforehand, the overall research problem will not be adequately addressed, and any conclusions drawn will run the risk of being weak and unconvincing.
Epidemiological information is used to plan and evaluate strategies to prevent illness and as a guide to the management of patients in whom disease has already developed. Like clinical findings and pathology, the epidemiology of a disease is an integral part of its basic description.
In this session, we're going to look at three topics shown on the slide. We're going to look at, first of all, choosing a research design. Second of all, the strengths and weaknesses of different methodologies. And thirdly, quantifying risks and benefit using the odds ratio. The odds ratio is a key measure in epidemiology, and we're going to relate that to looking at causal research designs. Causal research designs occur when variation in one phenomenon, an independent variable, lead on average to variation in another phenomenon, the dependent variable. For example, how much drug a patient receives and the probability of having a good outcome or an adverse effect. In terms of research design, we'll focus on the unfiltered information part of this pyramid here, which represents quality of evidence. You can see that at the top part of the unfiltered information section, we have randomized controlled trials going down through cohort studies, case control studies, and expert opinion. For now, we're going to focus on cohort studies. Cohort studies measure potential causes before an outcome has occurred. So, for example, I and my colleagues at Kiel did a study looking at melatonin, hypnotics, and their association with fracture, entitled a matched cohort study. So in other words, we looked at exposure to melatonin, and then later on we looked to see what the risk of developing a fracture was. So cohort studies can demonstrate that causes precede outcomes, thereby avoiding the debate as to which is the cause and which is the effect, which sometimes can occur in epidemiological studies. In cases where a comparative analysis of two cohorts is made, for example, in this case looking at the effects of people who take melatonin and people who take hypnotics, one of the issues is that a researcher cannot control for all the other factors that might affect the two groups. These factors are known as confounding variables, and we try to control for these variables using statistical methods. However, due to the lack of randomization in the cohort design, its external validity is lower than that of randomized control trials, where the researcher randomly assigns participants. So another way to think about this is that cohort studies are a type of observational study. And this slide shows the different types of observational study. We have cohort studies down here, case control studies, and cross-sectional studies. So if we follow it from the start, we can see, did investigator assign exposures? So remember, the question that I was looking at was melatonin in relation to other drugs, and did this affect outcomes? So yes, I did assign exposures, which was receiving melatonin or not. Was it an experimental study? No, it was an observational study. Was there a comparison group? Yes. Was it an analytic study or a descriptive study? It was an analytic study. Did I look at the direction in which things happened? Yes, I looked to see whether it was the melatonin preceded the occurrence of a fracture. So this leads us down to the cohort study branch. So it's always important to think of the type of study in relation to the research design. So one of the rationales for observational studies, such as cohort studies, is that they can be used to see whether the results of randomized controlled trials occur in real-world settings. That's shown in this point here. A second point is that depending on the type of study, they can also provide a lot of information about patients. So for example, in the melatonin study, I was able to see whether people had had a previous fracture. One final point about observational studies is that they shouldn't be confused with qualitative studies. Although they're observational, they're still collecting numerical data about patients rather than qualitative information about patients. So I've mentioned the melatonin study that I was involved with as an example of an observational study, and here is another example. This is an observational study, which is a cohort study, and it's entitled A Canadian Naturalistic Study of a Community-Based Cohort Treated for Bipolar Disorder. So again, it's always important to think about what the objective of the study is. And in this case, the authors wanted to look at bipolar illness, which is associated with significant morbidity and health resource utilization. And the background states that second-generation antipsychotics used alone or in combination with mood stabilizers are effective in treating acute mania. This study was designed to compare the changes in clinical parameters at 1 month in a group of patients who required treatment intervention for the exacerbation of mania. So it's very precise objective. And what they did was they compared two groups of patients. They compared a cohort patient who received olanzapine added to their medication regime, or the dose of olanzapine was increased. And they compared this with the other cohort who had a medication other than olanzapine added or the dose adjusted. We'll take a look at some of the study characteristics. First of all, we should mention that the patients in the two cohorts were matched as closely as possible based on their health status, utilization of psychiatric and emergency services, and drug and alcohol indicators. So the results show that at 1 month, patient in the olanzapine cohorts recorded a mean reduction in the Young Mania Rating Scale of 11.5, and this was significantly greater than the mean reduction in the other cohort. So we can take it from this that the results not only reflect this sample, but would apply to wider population. The olanzapine cohort was significantly improved compared to the other cohort on scales for depression and anxiety, and did not experience deterioration in physical functioning seen in the other cohort. At 1 month, no significant difference were detected in a variety of other measures. So I just want to mention one point in this, which is the statistical measure used here, which is ANCOVA. So although you don't need to understand all the details of ANCOVA, you should know what ANCOVA stands for. And what it stands for is analysis of covariance. And we'll look at this in more detail when we come to look at statistical tests. But essentially what we're doing is looking at the relationship between a dependent variable, which is the type of drug that they were receiving, and an outcome variable, which in this case is the score on the mania rating score, and it's going to control for a number of variables. So that summarizes some of the key characteristics of a typical observational research study. So now we're looking at another way of looking at bipolar disorder. This is from a paper called What Happens After Diagnosis: Understanding the Experience of Patients with Newly Diagnosed Bipolar Disorder. So this time it's trying to get a more holistic understanding of bipolar disorder, so that rather than using quantitative methods, it's using interviews to try and understand more about the patients. So we can see from some of the results that patients cited unwanted side effects, coping with unpleasant symptoms, uncertainty about their future, and so on. And the point is that such data are also important for clinicians to take into account when they're working in partnership with data. So it's not that one type of study is more important than another. It all depends on the type of research question that you are interested in. So qualitative research is by definition stronger on narratives than statistical tables. The problem that arises is, how does a researcher go about categorizing the events or activities that people describe? One issue is that quotes may be selective and therefore not representative. It could be that the researcher's biases play a part in organizing the data. Another is that while people may not tell untruths about their past, they may choose to highlight certain features of their situation which fits in with a certain narrative of their illness. So for all these reasons, qualitative research, while important and answers many important questions, is not something that's rated highly in terms of evidence-based medicine. So let's look at some of the attributes of qualitative research. Some of the attributes are that it involves open, not closed questions, focus on meaning, that it's exploratory, not explanatory, and involves grounded theory. So what do these statements mean? Open-ended questions are broad and can be answered in detail. For example, what do you think about this medicine? While closed-ended questions are narrow in focus and usually answered with a single word or picked from multiple choice items. Are you satisfied with this medicine? Yes, no, mostly, etc. In terms of meaning, the goal of all research is obviously to draw meaning from the data, but qualitative research is unique in the various aspects of qualitative research. Qualitative researchers derive meaning from the data by means of multiple sources, evaluating many factors such as the context, the language used, the impact of the participant-researcher relationship, the potential for participant bias, and the potential for research bias. Explanatory research is defined as research used to investigate a problem which is not clearly defined. It is conducted to have a better understanding of a problem, but will not provide conclusive results, unlike the quantitative studies that we've looked at. For such research, a research usually starts with a general idea and uses this research as a medium to identify issues that can be the focus for future research. The last thing that we'll look at is grounded theory. Grounded theory is a research method that operates almost in reverse from traditional research, and at first may appear to be in contradiction to the scientific method. Rather than beginning with a hypothesis, the first step is data collection through a variety of methods. From the data collected, the key points are marked with a series of codes which are extracted from the text. The codes are then grouped into similar concepts in order to make them more workable. From these concepts, categories are formed which are then the basis for the creation of a theory, which can then be tested out using other methods. So we'll have a review question now. And the question is, which one of the following is not normally an attribute of qualitative research? Is it open questions? Is it the fact that it's exploratory, not explanatory? Is it the fact that cases are randomly selected? Is it because there's a focus on meaning? Or is it because it uses grounded theory? So which one of these is not normally an attribute of qualitative research? The review question asked, which of the following is not normally an attribute of qualitative research? And the answer is C, cases are randomly selected. This is more often associated with quantitative research, which we'll come to look at when we look more at statistical concepts. In qualitative research, there are various sampling techniques that you can use when recruiting participants. The two most popular techniques are purposive and convenient sampling because they align best with qualitative research design. Purposive sampling is a sampling technique that qualitative researchers use to recruit participants who can provide in-depth and detailed information about the phenomena under investigation. It is subjective and determined by the qualitative researcher generating the criteria each participant must meet to be considered for the research study. In convenient sampling, this is a technique that qualitative researchers use to recruit participants who are easily accessible and convenient to researchers. This might involve using a particular location that makes recruitment convenient. This slide summarizes some of the key features of the two methods that we've been looking at. Quantitative methods as illustrated in the cohort study and qualitative methods as illustrated in the paper looking at the experiences of patients with bipolar disorder. So, in the quantitative studies, the focus is on facts and causality, looking for fundamental principles. In qualitative, the focus is more on meanings. So if we look at the two methods, quantitative and qualitative, we can see that they're associated with different types of methods. The quantitative being associated with experimental methods or database, numerical databases, whereas qualitative studies are based on observations and interviews. In the quantitative study, we saw that the focus was on quantifying the effect of a drug, so how many of something. Whereas in the qualitative, we were more concerned with understanding the nature of experiences. So what is the nature of that experience? The quantitative method was starting off with a hypothesis and then making a deduction from that hypothesis that we can then test out. Whereas the qualitative method is starting more from observation of facts and then building up from that using the inductive method to come up with some general principles. In the quantitative approach, we're using sampling methods, which is based on trying to achieve a representative and random sample, whereas in the qualitative approach, our focus is on selecting people who will provide interesting information in relation to our research question. So we can see that two very different types of methods, reasoning and sampling, associated with the two different types of methods. So this is another way of looking at the two types of design, the quantitative and qualitative. Quantitative, shown on the left here, is more associated with the natural science, and the concern is with objectivity. The researcher is not usually personally involved. Obviously, they're doing the experiment, they're analysing the data, but they personally are not involved in the study. It usually involves medium or large scale studies, so you may be looking at thousands of cases. You're concerned with explaining things, so you're concerned with coming up with theories that explain phenomena, and you're usually generalizing from the specific. In contrast, the qualitative approach is more associated with the social sciences, although social science also has quantitative studies as well. In fact, increasingly there are quantitative studies. But it's concerned with understanding things, as we saw with the example with bipolar. What does it mean to patients? What are the issues that they have with it? So the researcher tends to be personally involved. Their views may be manifested in the qualitative studies. Studies are usually small scale, involving small numbers of people, and the concern is with understanding people's concerns and beliefs and attitudes. And in contrast to the quantitative, it's more about interpreting specific occurrences of behaviour. So we'll have another review question. Which of the following is normally associated with quantitative research? Is it subjectivity? Is it research that's small scale? Is it interpreting the specific? Is it the natural sciences, or is it individuals? So is it A, B, C, D, or E? And the answer is that quantitative research is usually associated with the natural sciences. What about potential criticisms of the research designs? Again, if we think of the examples of the schizophrenia studies, this is a good way of thinking about limitations that they might have. The quantitative study that we looked at of schizophrenia in relation to the drug olanzapine, in that study, the main measure was a number on a rating scale. So arguably, the emphasis is on the data and the methodology, and complexity with regard to the effect of the drug is reduced to rather basic principles. The qualitative study was concerned with concerns with and difficulties following diagnosis. And arguably, one of the limitations of that approach would be that it's too subjective and it rules out the existence of science, in other words, drawing general principles. Too much focus on the individual, preventing generalizations, and that the knowledge gained in qualitative studies is not objective. Another important point to consider is whether the research hypothesis is potentially falsifiable. This applies both to papers that you're reading and also your own research project. It's easy to obtain confirmations or verifications for nearly every theory. If we set about looking for these confirmations, for example, if we are testing the idea that all swans are white, and we go around looking for white swans, of course we will find lots of white swans, but there are in fact black swans as well. They're very rare, but there are black swans, so the theory is not correct. Also, for example, if we look at a topic such as the one I mentioned earlier, of the drug melatonin, and if our research hypothesis is that melatonin is reported to be a safe drug, of course we could find many confirmations that melatonin is a safe drug. However, this is not always the case. There are examples where this was not found to be true. So A theory which is not refutable by any conceivable event as specified in the research design is not scientific. So this might sound trivial, but in fact a lot of research projects are set up so that it's much easier to find evidence in support of the theory than evidence against the theory. And Karl Popper, who was the philosopher who really developed this theory into the falsification principle, wrote that irrefutability is not a virtue of a theory, but a vice. So it's not a good thing that a theory is only supported by facts. You have to be able to find facts which do not support the theory as well. Building on this idea of falsifiability, let's look at a related idea, the idea of the null and the alternative hypothesis. And we'll look at it in relation to something that I'm studying at the moment, which is polypharmacy. So let's look at how we might set out the null hypothesis and the alternative hypothesis. The null hypothesis is a statement used to put forth an argument that will be accepted unless it can be shown to be incorrect beyond a reasonable doubt. The alternative hypothesis is a claim about the population that contradicts the null hypothesis and what we can conclude when we reject the null hypothesis. So the null hypothesis might be something like polypharmacy will not improve health outcomes in patients with atrial fibrillation. And the alternative hypothesis would be polypharmacy will improve health outcomes in patients with atrial fibrillation. So it's good practice to set out your research question like this, and we can relate this to what we looked at in relation to the falsification principle. And scientists do this to say, okay, let's assume that there's no difference, and now let's try to disprove that theory. So to write a null hypothesis, first start by asking a question such as, what is the effect of polypharmacy in patients in atrial fibrillation? And then rephrase that question in a form that assumes no relationship between the variables. And statistically, what you do is you test the alternative hypothesis against the null hypothesis. One does not exist without the others. In papers, it's common to develop the alternative hypothesis and leave the null hypothesis implicit. You expect either a positive or a negative effect, and you're testing it against no effect. The null hypothesis is implicitly assumed in the mind of your readers. Another important concept is that of causality. How do we know that something causes something else? And the example that I'm going to use is the example of the relationship between cannabis use and schizophrenia. So there are papers in the literature that suggest that specifically cannabis, as opposed to other drugs, can cause schizophrenia. But there's evidence both for and against this hypothesis. So what are the ways in which we would judge whether this is a causal association or not? Bradford Hill, who's shown in the slide here, developed a range of criteria by which we can judge causality, and just some of them are shown in this slide here. So we'll just go through some of them. The first one that we'll look at is temporality. In other words, this is a necessary association for causality. The exposure must occur before the outcome. If somebody has schizophrenia and then they take cannabis, then it can't be that the cannabis causes the schizophrenia. So looking at the order of things is very important. And second of all is the idea of the strength of the association. And shortly we're going to be looking at how we measure strength of association. But if a study shows a very large effect of something, for example, the effect of cigarette smoking and lung cancer, then that can be taken as evidence for causality. The next thing that we want to look at is specificity. Is it only, if somebody's taking multiple drugs, how do we know that it's the cannabis that's associated with schizophrenia? So obviously there have been studies that have looked at other drugs, and where the studies have only looked at cannabis, then this could be taken as evidence for specificity. Next, we come to consistency. If we look at studies that are conducted at different places and in different times with different populations, but of the same basic phenomena, are they all coming to similar conclusions? If they are, that's evidence for consistency. And finally, there's the idea of biological plausibility. The association that we're observing should fit with the known facts of the natural history and biology of the disease. And here I'm going to look at an example which was related to another study that I did looking at something called the hygiene hypothesis, which is something that has been used to explain asthma, for example. The hygiene hypothesis states that early childhood exposure to particular microorganisms protects against allergic diseases by contributing to the development of the immune system. And this coheres with trends in developed countries where there are both fewer childhood infections and an increasing incidence of allergic and autoimmune disorders. So this slide shows the ways in which we can judge whether there's evidence for the causality of the phenomena that we're looking at. So we've looked at causality, and now we're going to have a review question. So the question is, which one of the following is not on Bradford Hill's checklist for judging causality? Is it temporality, strength, observation, specificity, or consistency? So the question asked, which of the following is not on the list for judging causality? And among the options, one of them which is not involved in judging causality is observation. Of course, it is an important part of experimental method, but it's not part of the checklist for judging causality. Now we come to one of the most common measures of association in epidemiology, and that is the odds ratio. Odds ratio are a measure of association in both case control studies, and they can also be computed in a cohort study. Bradford Hill suggested that strong associations were more likely to be causal than weak associations as measured by the odds ratio. For example, in studies of smoking and lung cancer, those who smoked had a 20-fold increase in the risk of lung cancer, meaning that it's more likely to be attributable to smoking than uncontrolled confounding. However, relatively weak associations are common in epidemiology, so we have to rely on strong study design and methodology to minimize bias. And this is often difficult in studies of human health. We've already talked about this in relation to cannabis use and psychosis, where it's very difficult to separate cause and effect. And this study is one of the few studies where it may be possible to do that. It's a cohort study. It's a longitudinal prospective study, meaning that people were studied from a young age for many years. We'll focus on some of the variables just to illustrate the odds ratio. So what we have is 759 people in this study, and they were asked about their cannabis use at 15, and they were assessed for schizophreniform disorder at 26. So the odds involves comparing one outcome versus another. In this case, whether they were diagnosed versus whether they weren't diagnosed. So we can compute the odds ratio, dividing the yes by the no for the two outcomes, and then we divide them to get the odds ratio. So you can see here that the odds ratio comes out at 3.71. So they have a threefold increase of people who smoked cannabis at 15 or had a threefold increase. Another way of interpreting this is that their risk is 271% higher In other words, what we do is we multiply this by 100, and in order to get 371, and we take away 100 from it, and we get 271%. It's interesting to note that in the paper, actually, although this seems like a very high figure, actually this was reduced after other factors were controlled for, especially having psychotic symptoms at an earlier age. But for now, I just want to focus on the computation of the odds ratio. So one way of thinking about that is I'm going to compare the actual data with hypothetical data to illustrate what would happen if the odds ratio was 1. In other words, there's no difference between the two groups. So you can see what I've done here is I've taken the same number of cases, 759, but I've divided them differently so that in each case the odds is 1. So 10 divided by 90 gives an odds of 0.111, and 66 divided by 593 gives an odds of 0.111. And we divide one by the other and we get an odds ratio of 1. So we can see in this hypothetical example, there's no difference between the two. So by comparing an odds ratio with a value of 1, we can see what the excess risk is. In this slide, I'm going to look at another measure of association called the relative risk. Relative risk is more popular in cohort studies, and in some ways it's easier to interpret. Now, in a cohort study, we've seen that you define the groups based on exposure, then follow them through time. Because you specify the starting conditions, risk as we've defined it makes sense. That is, over time, we can observe the chance of each person in the cohort developing an outcome. So I'm just going to look in this slide at how we compute the risk ratio and consider it in relation to the odds ratio. So the data are organized in a similar fashion as we saw in the last slide. In this case, we're going to look at passengers on the Titanic. And we can see that the data are organized in a similar fashion. We've got 1,300 people, we've got 462 female, 851 males. Some died and others were alive. The difference this time is that instead of contrasting one outcome to the other, which is the odds ratio, is that we look at the probability of being dead or alive in the two groups. And that kind of intuitively makes more sense. For example, if we have a dice with 6 sides, we want to know what are the chances of throwing a 6. Well, there's 6 sides, so the chances are 1 in 6. We're looking at one outcome versus all the outcomes, whereas in the odds ratio, we're looking at one outcome versus the other, so the odds would be 5 to 1 against. So you can see it's slightly less intuitive. So if we look at the risk of females dying, we can see that it's 154 over 462, which I've shown you down here, comes out at 0.33. And for males, the probability of death is 83%. That is 709 out of 851. So we ask, what's the relative risk of dying? We divide for males versus females. We can see that it's 0.833 divided by 0.333, which gives a relative risk of 2.45. If we ask the question in a slightly different way and we ask, well, what's the difference in terms of females and males surviving? This time we would compute 308 divided by 462, etc. I won't show you all the workings, but the key point is that females are 4 times more likely to be alive. And so it's slightly confusing because the estimates of risk for being dead or alive are different. And so that is something that you don't get when you use odds ratios of the same. So that's one of the reasons why odds ratios are more popular than relative risk, but it's important to be aware of the difference between the two measures, as you'll sometimes see one rather than the other being reported in papers. Let's look at the same data, but this time we're going to calculate the odds ratio and compare that to the relative risk. So with the odds ratio, what we're comparing is one outcome versus another, and we're comparing it for two groups, for females and for males. So if for females the odds were 2 to 1 against dying, what does that mean? That means that there was 154 who died and 308 who survived. So the odds are in favour of surviving rather than dying. So the risk of dying is less than 1, 0.5. For males, you can see the pattern is quite different. So there, the odds favour death. So 5 times more likely to die, 709 divided by 142. And if we divide up here 5 by 0.5, we get the odds ratio for dying. Okay, so you can see that the value is 10. If instead we want to look at the odds of alive versus dead, we would just reverse this. We would divide 308 by 154, 142 divided by 709, and we would get these figures. And we would see that the odds ratio comes out to the same. So that's one of the strengths of the odds ratio. It doesn't matter which way round we compute it. However, we can see that compared to the previous slides, the odds ratios is much higher, and it really depends on the exact data set that you have. Sometimes the odds ratios and the relative risks are quite similar, and it's quite complex to go into all the different scenarios as to explain why it's different sometimes and why it's the same. The best thing is to have familiarity with the data so that you understand where the odds ratio or the relative risk are coming from. So now we're going to have our revision question. Unlike the previous questions, this isn't a multiple choice question. This involves a simple calculation, and the calculation is to assess the odds ratio for developing heart disease if you smoke or don't smoke. So the data are shown in the table here. We can see that there are 1,000 smokers and 1,000 non-smokers. We can see that for those who smoke, 200 out of the 1,000 develop heart disease, and for those who don't smoke, 100 develop heart disease. So the question is, how do you calculate the odds ratio? Okay, so if you have a go at that, and the answer will appear in the next slide. So just remember the difference between the odds ratio and the relative risk. So this slide shows how we calculate the odds ratio. We can see the two groups, the smokers and the non-smokers, and the odds for developing heart disease for the smoker are 200 divided by 800. Remember, one outcome versus the other, so 0.25. So we can see that for the smokers, most people do not develop heart disease. The odds are 0.25. For the non-smokers, 100 develop heart disease, 900 don't. So for them, the odds are lower. So when we divide one by the other, we get 0.25 divided by 0.11 equals 2.27. So we can see that the odds ratio is higher for the smokers compared to the non-smokers.
Numbers needed to treat tells us how many patients must receive a particular treatment for one additional patient to experience a favourable outcome, such as treatment response. Numbers needed to harm tells us how many patients must receive a particular treatment for one additional patient to experience a particular adverse outcome. Lower NNTs and higher NNH values are associated with a more favorable treatment profile. If the NNT is smaller than the NNH, does it mean that the risk-benefit ratio is favorable? Not necessarily. Clinicians need to make a subjective judgment about the value of the benefit and the seriousness of the risk. For example, a drug may have an NNT of 3 for pain relief and an NNH of 50 for blood dyscrasia. Even though the blood dyscrasia is far less likely to occur than pain relief, the seriousness of the dyscrasia would certainly discourage the clinician from prescribing the drug. Surprisingly, almost nobody who cites an NNT value mentions the time frame for that value. Consider the statin NNT that was referred to earlier. 50 to 200 low-risk subjects must take a statin for 5 years for one additional subject to benefit. What if the time frame had been just 3 months, or if it had been 20 years? Obviously, a long time frame is more discouraging. The figures in this slide are taken from the cannabis and schizophrenia example that we looked at earlier. In that study, we saw the odds ratio was 3.71. In other words, people who took cannabis were 271% more likely to develop schizophreniform disorder. In this study, we saw that the absolute risk of schizophrenia, or actually more precisely schizophreniform disorder, was around 3% among those not taking cannabis, which is a fairly high estimate. Using these figures, we can see in the slide that the NNH is 14, which is high. In other words, 14 people using cannabis at age 15, instead of not using it, would result in one new case of schizophreniform disorder at age 26. Other studies have found a much higher NNH because the incidence of schizophrenia in these studies, as opposed to schizophreniform disorder, was much lower. In these studies, the NNH was in the thousands. In other words, thousands of people would have to use cannabis to produce one extra case of schizophreniform disorder at age 26. So this example shows that the definition of harm and the baseline risk are very important.
Let's look at how the NNT and the NNH are calculated. First note that the ARR, the absolute risk reduction, is the amount by which a therapy reduces the risk of the bad outcome for the risk factor or therapy compared to the control group. Note that this can be negative. In other words, there might be an increase in the bad outcome. In this example that we looked at, the control rate, that is schizophrenia with no cannabis use, is 3%. The experimental rate, schizophrenia rate after cannabis use, is 10.3%. Note that you can define these groups according to the study. The answer will only differ in terms of whether the outcome is positive or negative. So here we can see how the ARR is calculated, and we can see how this is converted to the NNH, which in this case is 13.7. So as mentioned previously, 14 people using cannabis would result in one new case of schizophrenia. Let's consider another example. If a drug reduces the risk of a bad outcome from 50% to 30%, the control rate is 50% and the experimental rate is 30%. So the ARR is 0.2. We convert this to the NNT, which is 5. So if a drug has an NNT of 5, it means you have to treat 5 people with the drug to prevent one additional bad outcome. However, let's look at another closely related example. If 50% of patients report improvement to a placebo drug and 70% report improvement for an antidepressant drug, what is the NNT for the antidepressant drug? So again, we do the calculation, and this ends up with an NNT of 5. Again, 5 patients would have to receive treatment with the antidepressant drug to prevent one additional bad outcome. So we can see here in these two examples that we've just looked at, we have the same NNT, but there are different rates of improvement. So caution is required with interpretation.
About the NNT or the NNH for commonly prescribed drugs. In this slide, we look at people who take statins for 5 years. Statin medications are aimed at an enzyme in the cholesterol production pathway and are therefore intended to reduce cholesterol. In some patients, elevated cholesterol plays a role in the development of coronary heart disease and heart attacks. So the drugs are intended to reduce the chance of death by reducing heart attack and strokes. These data examine the effect of statin for people who have known heart disease or a history of stroke. The effectiveness of the statins is fairly consistent across studies in this group. They lower cholesterol in most people who take them. A few people will avoid a heart attack or stroke by virtue of this change. After 5 years of daily statin therapy, study subjects achieved a 1.2% lower chance of death, a 2.6% lower chance of heart attack, and a 0.8% lower chance of a stroke. As a public health measure, this suggests that statins may have an identifiable effect, because while the chances of any one individual being affected are small, for example, 19 out of 20 people who take the drugs have no effect. When 1 million people take them, then roughly 45,000 people will see some benefit, while another 6,000 may see harm. There's a caveat to this. Virtually all the major statin studies were paid for by pharmaceutical companies. There's a long history of misrepresentation of data, and these results may be more optimistic than subsequent data produced by researchers that do not have a financial stake. However, these additional studies may take years. Also, harms from these drugs are difficult to predict, partly because harms are difficult to anticipate and are often poorly tracked. Such findings often come up years after new drugs have been on the market.
So we've looked at how some key statistics are calculated. What about the interpretation of statistics? I want to show an example from a paper, and the paper is called Primary Care-Based Randomized Double-Blind Trial of Amoxicillin versus Placebo for Acute Otitis Media in Children aged under 2 years old. So the authors wanted to determine the effect of antibiotic treatment for acute otitis media, and they had a randomized control trial. It was in 53 general practices, 240 children, and there was an intervention versus placebo, and there was a range of outcome measures, including persistent symptoms at day 4 and duration of fever and pain or crying. And the key question here is there a difference between those children who received amoxicillin and those who received placebo? So it seems a fairly straightforward study design, and it's a randomized control study, so it's the highest level of evidence that one might obtain in looking at this research question. So let's look at just one of the key findings of the paper. One of the key findings was that persistent symptoms at day 4 occurred in 59% of the children in the amoxicillin group and in 72% in the placebo group. So we're comparing 59% versus 72%, and the difference in this risk is 13%. And the confidence interval, which we'll look at in a later session, is 1% to 25%. In other words, how do we translate this sample into the population? Another key measure was that the median duration of fever was 2 days in the amoxicillin group versus 3 in the placebo group. So the question is, what do we conclude from these data? What does statistical significance mean in this situation? So what the authors have done in this paper is they've translated the level of risk from a number to the population. And the paper says that 7 to 8 children aged 6 to 24 months with acute otitis media needed to be treated with antibiotics to improve symptomatic outcome at day 4 in one child. So 7 to 8 need to be treated in order to reduce symptoms in one child. And they go on to say that this modest effect does not justify the prescription of antibiotics at the first visit, provided that close surveillance can be guaranteed. So in other words, what they've done is consider the statistical results in relation to the clinical considerations, and they conclude that although there's a statistical difference, it does not equate to clinical significance. So they say that this modest statistical effect does not justify the prescriptions of antibiotics, provided close surveillance can be guaranteed. So this might seem quite unusual because many studies, for example, that look at the effectiveness of drugs would simply say, well, if there's a statistical difference, this equates to a clinical significance. So it's always worthwhile thinking about how the statistics relate to clinical significance. And here we can see that what they've done is they've translated the statistics to considerations of how this would relate to the population. What's interesting about this paper is that there are comments on the website that show that not everybody agrees with this interpretation of the absolute benefit of amoxicillin to treat otitis media, whereas the authors of the paper thought that the benefits were not sufficient. This writer disagrees. He writes, "Let's see if I understand this correctly. Of the two groups, I should choose for my patients the no antibiotic group, where there is more fever, more pain, more analgesia, 1% chance of meningitis, more treatment failure, and more hospitalizations." And he concludes, "I have to say that I take away from this study a different conclusion from the authors." So what's interesting is the relationship between statistical findings in a paper and how we interpret those statistical findings.
What most people want to know is the absolute risk of developing a disease rather than the relative risk. Absolute risk of a disease is your risk of developing the disease over a time period. Relative risk is used to compare the risk in two different groups of people. For example, the groups could be smokers and non-smokers. We can illustrate this with an example. Say the risk of developing a disease is 4 in 100 in non-smokers, and say the relative risk of the disease is increased by 50% in smokers. The 50% relates to the 4, so the absolute increase in the risk is 50% of 4, which is 2. So the absolute risk of smokers developing this disease is 6 in 100. This is an example when talking about treatments. Say men have a 2 in 20 risk of developing a certain disease by the time they reach the age of 60. Then say research shows that a new treatment reduces the relative risk of getting this disease by 50%. The 50% is the relative risk reduction and is referring to the effect on the 2, and 50% of 2 is 1. So this means that the absolute risk is reduced from 2 in 20 to 1 in 20.
So in this presentation, we've covered quite a wide range of topics. We've looked at different approaches to research design and study methodologies. We've looked at two measures that are often reported in papers, and we've considered how statistical significance relates to clinical. These are all important issues, both in relation to reading and studying papers that you might come across, and also to designing your own research project.